Hi, everyone. Welcome back to Dakewe College of Continuing Education online webinar again. So tonight's lab web broadcast is very special. So our audiences are not only from mainland China, but also from different countries, such as Southeast Asia, Europe, US, and South America. So welcome all the audiences who came to DCC for tonight's webinar for the first time. So as the #1 brand in Chinese pathology device industry, Dakewe has its products over the world. So we also have the responsibility and the obligation, we can say that, to build up a pathology knowledge exchange platform so that more and more pathologists can learn and understand the practical experience of pathology experts from different countries. Singapore General Hospital Digital Pathology Service is a global leading pioneer in this field. And Dr. Cheng is the director of this platform. So that's a great honor. We may be able to invite him to DCC to share his professional knowledge. So he will be the lead presenter for tonight's webinar. And also, we are really glad to invite Dr. Shi Ruoyu from the Department of Anatomical Pathology in the Singapore General Hospital. So tonight, our moderator, Dr. Liang Li, is the Director of Pathology in Nanfang Hospital. She's also the Pathology Director in School of Basic Medical Science, South Medical University, China. So thank you to the three professors to attending tonight's lecture and share their experience and the recent advances in digital pathology. So, okay, next we would like to invite Dr. Liang to start host tonight's webinar. Dr. Liang, please.
Okay, thanks, Lei, for introducing me. I'm so glad to be the moderator of this virtual meeting. Tonight, it's a great honor to have Professor Chen Qilong as a leading presenter and Dr. Shi Ruoyu as a panelist. First of all, let me introduce the resumes of two professors. Dr. Chen Qilong is a senior consultant of the pathology of anatomical pathology in Singapore General Hospital. He is also director of computational and digital pathology division of pathology in Singapore General Hospital and Single Health Academic Clinical Programs Assistant Professor. He was actively involved in the implementation and rollout of the digital pathology system in SGH and the expansion of the digital pathology solution program. We are looking forward to your wonderful lecture tonight. Dr. Shi Ruoyu, please move on. Dr. Shi Ruoyu is associated consultant of pathology of anatomical pathology in Singapore General Hospital. He will share his areas of interest in pathology, digital pathology, and uropathology. Tonight he will share his views with us and discuss some issues. Now let's welcome Professor Dr. Cheng to bring today's lecture. The topic is digital pathology, establishing the digital foundation for computational pathology. Welcome, Professor Cheng.
Thanks, Prof. Liang, for the introduction. 晚上好，我是曾子龙医生。我首先感谢主办方给我这次机会来讨论数字病理以及它对于解剖病理 数据科学与分析的重要性啊，我要感谢梁教授的介绍以及石医生帮我做的中文翻译。我将会以英语演讲，并在 PPT 里适当的地方加入中文注解。Good evening. Many thanks for Prof. Liang's introduction and Dr. Shi for the Chinese translation of the slides. I'm Dr. Cheng and I would first like to thank the organizer for giving me the opportunity to talk about digital pathology and how it is important to our data science and analytics effort in anatomical pathology. This lecture will be conducted in English with Chinese translation shown in the slides at appropriate junctures. So what is digital pathology and what is the impetus for digital pathology? I will begin first by providing some explanation of nomenclature, followed by background on histopathology and what problems we are facing with our current practice. I'll first start off by clarifying some of the nomenclature. Within this lecture, I will commonly refer to whole slide imaging when I mention digital pathology, which is commonly the case for most digital pathology literature and publications. But digital pathology actually encompasses more than whole slide imaging, as you can see here. If we look at the whole scope of digital imaging and image modalities that an anatomical pathology department has to handle, this will include gross photograph of specimens, photomicrographs, which may be microscopic snapshots, electron microscopic images, immunofluorescence images, etc. Live microscopy, which may include robotic arms and controls, or via teleconferencing with human controls. And even paraffin block images, which has recently been introduced to help with quality control process. All these imaging and image modalities in anatomical pathology should be encompassed in the broader scheme of digital pathology, which is subsequently a subdiscipline within the bigger umbrella of pathology informatics. For the purpose of today's talk, I will be referring mainly to whole slide imaging. So just a bit of history of histopathology. The techniques currently used in histopathology took shape in the late 1800s. Microscope development dates back to as early as 1600s. Microsome capable of sectioning thin tissue dates back to 1850s, allowing us to make micrometer thick sections so that light can differentially pass through stained tissue for microscopic examination. Automated tissue processes dates back to 1945, allowing tissue fragments to automatically pass through chemical agents and be hardened into paraffinized tissue fragments that can then be included into paraffin blocks for thin sectioning. With the automation, we can do it in scale. The last major milestone is routine use of immunohistochemistry, which exponentially increases since 1980s. And the most well-known is the staining of breast cancer for estrogen receptor, progesterone receptor, and HER2 to inform the oncologist about treatment and prognosis. In histopathology, what have not changed over the past century is the use of thin tissue sections mounted and stained on glass slides and examining them through the microscope. So have we progressed? Yes and no. Yes, because we currently have two happy pathologists looking through the microscope, which has better illumination, higher magnification, and convenient stage movement of the glass slides. And no, because we are still working with glass slides, handling glass slides, and facing the constraints of use of glass slides. And we cannot do much with the glass slides per se, except to examine them under the microscope. Some of the constraints of glass slides you can see is that glass slides are physically vulnerable, and you can see two broken slides here. Glass slides can fade such that they can be hardly seen, the morphology, after leaving the glass slides for some time. This results in loss of precious diagnostic material, some of which are the sole evidence of disease. In addition, there's the physical constraint of the glass slide. We use the glass slides for so many different purposes, ranging from diagnosis to multidisciplinary meetings, as well as for teaching and research. But with physical slide, we can only use it for one purpose at any one point in time. And if we are not using it actively, it will be filed away, sometimes off-site, and may not be readily retrievable, sometimes taking days before you can obtain the glass slides, which may be needed for diagnosing a current case. We are able to break through these constraints with the use of digital pathology technology, which digitize slides into virtual copies known as whole slide images. It is like taking a picture, but at very high magnification throughout the entire slide. To produce the whole slide image, we need to load them into whole slide imaging machine that can be seen on the left, where a medical technologist is actually loading the slide into the machine. The machine will capture images of the slide at high magnification, commonly at 20 times or 40 times objective equivalent, frame by frame, and stitch the microscopic images together into an entire slide that can be navigated through at various magnifications, much like panning and zooming through digital maps that you can see in the middle. And we can now see a happy pathologist reading a whole slide image on the right. This really breaks down the constraints we once have with glass slides, finally allowing us to use the whole slide image for as many purposes as we need. It also breaks barriers and silos, allowing multiple pathologists to access the same slides at the same time, even if we are far apart. We can now even share cases internationally, allowing collaboration in diagnosis, teaching, and research with our overseas colleagues. However, what we're looking forward to is unlocking the potential of the digitized slides with computational technology. As you can see, the ability to convert our glass slides into digital images also opens the window for us towards introducing methods and modalities that we weren't able to perform with glass slides, like image mining and content-based image management to gain knowledge and potentially retrieve like images with known diagnosis in an image database to assist the pathologist. Precision biomarker analysis by using image analysis and machine analysis, which I will touch upon later, and new image perspective like three-dimensional image reconstruction, hence putting the histopathology laboratory closer to being a smart laboratory. I will now switch gear a bit to talk about how we set up our digital pathology system, the important factors to consider when we embark on the digitization journey, before talking on how we are using it for analytics. Just a brief background about Singapore General Hospital. We are the largest hospital and academic medical center in Singapore. We have around 1,800 beds, a staff strength of close to 10,000, and an annual patient discharge exceeding 80,000, and close to 100,000 operations per year. The Singapore General Hospital campus also comprises 4 specialist centers, namely the National Heart Centre, National Cancer Centre, National Dental Centre, and Singapore National Eye Centre. Our anatomical pathology department in SGH is the largest anatomical pathology department in Singapore. It supports SGH and the specialist centers in the SGH campus and affiliated institutions. We have about 30 staff pathologists, about 15 residence trainees and fellows, produce close to 500,000 slides per year, and perform about 60,000 immunohistochemistry tests per year. Just a brief background on our digital pathology journey. In 2009, we piloted whole slide imaging implementation, which supports predominantly education and research. In 2011, having tested the technology and felt satisfied with it, we planned for expansion of the whole slide imaging into the diagnostic workflow. We implemented the new whole-slide imaging solution or digital pathology system to support the expanded use. And in 2014, we deployed the new digital pathology system for clinical use. Having used it for more than 5 years, we had gone through a phase 1 tech refresh and data migration, which is basically an upgrade of the technology that we currently have. And this year and next year, we will be further expanding the digital pathology solution so that we can cover the full histopathology workload and be able to digitize all the slides we produce in the laboratory. I will here on refer to our digital pathology system as DPS. In the brief window between 2011 and 2013, we studied the laboratory workflow and possible digital pathology touchpoints comprehensively and introduced some preemptive workflow changes. Our main objective in the 2013 Digital Pathology Expansion Project is as follows. The ability to integrate whole-slide imaging into the diagnostic workflow, including integration with the Laboratory Information System, or LIS. Ability to support remote consultation between the frozen section laboratory in the operating theatre and the main laboratory in academia, which is quite a distance apart. And the ability to support collaboration and remote access to images beyond SGH campus. Just a quick overview of our setup. We have a centralized digital pathology system, or DPS server, with storage housed in our local data center in our hospital, which coincidentally is in the same building as the laboratory. The scanners in the laboratory and the operating theatre supporting frozen section are connected via network to the DPS server, and the images stored can be accessed anywhere in the hospital campus. The DPS server is integrated via HR7 messaging with our laboratory information system for all the patient, specimen, and slide data. We also have a small server that we can export slides from our main server into. And this is isolated from our internal protected corporate network environment and can be accessed via the internet, allowing us to connect ourselves beyond our hospital and globally. This is a unidirectional transfer, so to avoid introducing any security vulnerability to our internal network. I would now like to illustrate the importance of the integration between the DPS and the LIS. Why do we integrate DPS with LIS? This is so that we can avoid manual double entry of patient and case data into separate solutions. Although the two-dimensional barcode can hold substantial amount of data, it is still limited for whole-slide imaging purpose, and in addition, potential for future discrepancy remains. Next, we can updates to patient and case metadata in LIS can be transmitted and updated by DPS seamlessly without manual intervention. We need to realize that case information evolves along the workflow in LIS. So standalone DPS implementation will suffer from increasing discrepancy of information with time. Next, this will provide sustainable information management and allow slide scanning to be readily scaled up. Although bulk of the information management remains in the LIS, we should not actually create a separate database in DPS that can result in discrepancy of information. And this duplication of effort with potential source of diversity is likely unsustainable. Lastly, if well designed, integration provides the potential for synergy between DPS and LIS in terms of functionality and business rules. And this will also allow us to overcome system limitation by novel means. However, integration with LIS is not plug and play and needs to be carefully studied and designed. As LIS have many users that may or may not have direct interest in DPS, but these users may be involved in workflows that may influence metadata updates to DPS. Integration with LIS requires a comprehensive implementation approach, including consideration of exceptions to ensure information integrity is not breached. And rollback of bad design decisions, particularly after system go live, may be difficult, and workarounds so required may be cumbersome. And deep engagement with the LIS vendor is essential for creative solutioning. Just a few key points to note on integration between DPS with LIS. The unique key for integration between DPS and LIS is the barcode holding the slide ID or slide identifier. Through the unique slide identifier, we will allow the information exchange to occur between DPS and LIS. LIS will update patient, case, and slide identifier to DPS, and DPS will update whenever images are scanned and imported or when images are deleted, so that the LIS will know when to link or unlink the DPS images with the case in the LIS. It is important to ensure all the materials can be accounted for at patient, case, specimen, and slide level. This may seem intuitive for in-house cases, but can be a problem when we talk about consult cases with only slides but no specimen, and the protocol in naming specimens or slides may differ from your own laboratory. I will now speak briefly about how we organize ourselves when implementing DPS. It took us about 7 months from kickoff till testing and clinical go live. Since our DPS is already a commercial out-of-the-box product that can be further configured to suit the laboratory's needs, it was important to start familiarizing the laboratory with DPS system early so that the laboratory was ready and our pathologist user champions could start to provide inputs about how they wanted the system to be configured and adjusted. To facilitate the laboratory workflow study and involvement, we have structured ourselves as shown. The project steering committee consists of senior laboratory and IT management to drive key decisions and milestones related to the project. The core team consists of a small group of pathologists, laboratory manager, IT manager, and medical technologists familiar with DPS, who are key in tactically pushing the project forward, and integrate inputs from the various participants of the extended project team that consists of a wide range of laboratory representatives performing various roles as seen on the right. The next key activity is the workflow study. We broke down our laboratory workflow into roughly 12 main workflows, which comprise not only workflows of immediate interest, but what it will be like in the future as we expand the use of digital pathology. These workflows also provide a checklist and scope for use in requirements, design, and testing. And it is important for each workflow to identify an appropriate user champion to drive the requirements around each workflow. I will now provide some examples of how we address patient, case, specimen, and slide accountability, so you can readily visualize what are the considerations when implementing DPS in your own laboratory. We will first touch on patient accountability. We need to keep in mind that the DPS must be kept up to date of the patient information changes and updates. For example, patient name or patient's unique identifier. LIS remains the source of truth for DPS, as there might be patient information sources other than the hospital information system. For example, if you receive a private consult case. This key premise remains one of the most intricate pieces to implement, as other upstream systems are involved, and the trigger needs to be as automated as possible. For example, any update of patient merge information from the hospital information system must flow down to the laboratory information system and subsequently flow into the digital pathology system. We also need to extend the patient concept to research and education scenario so as to maintain consistency in the metadata structure. And this requires a department-level naming convention. For example, for research, we used the project name and its associated metadata in a patient concept metadata. And for education, we use the education set name, example, more exam sets and conference sets, and its associated metadata into a patient metadata structure. We will now touch on case accountability by an example on frozen section. So before we talk about exactly what we are tackling, just let me explain a bit about our laboratory workflow and how we originally label the case or assign case accession numbers. We use case type as the basis for the prefixes in our case accessioning. Example, we used a PB prefix for surgical pathology and an NG prefix for non-gynecological cytology. Our frozen section laboratory is located remotely within the campus from the main laboratory. And pre-assignment of the biopsy numbers in the frozen section room, which we used to use pre-printed labels, as practiced in the main laboratory, was not possible as both the frozen section case and the routine case in the main laboratory were using the same prefix. Hence, upfront case accessioning of the frozen section specimen in LIS was also not possible. We review this issue 1 year prior to actual new DPS implementation. As you can see on the left, this is what we used to do. The actual PB case accession number in the LIS was actually in a blue ink that's labeled on the top. And there was a pencil mark that used to actually record a temporary frozen section number in the frozen section laboratory. So one of the aims of the project is for remote consultation between the frozen section laboratory and the main laboratory. Example, for subspecialty opinions, which requires scanning of the frozen section slide up front. Although it is possible to handle the scanning and entry of patient information manually into DPS without the LIS accessioning and labeling, this is not favored in view of the following: possible discrepancy with subsequent LIS accessioning, and combining with frozen section follow-up specimens is likely going to be a manual process in the DPS, and possibility of error, for example, mismatch, increases. So upfront accessioning is much more favored. So the working principle is we need to ensure that the case must already exist, i.e. the case must be accountable in the LIS and DPS at a point in time during scanning and not later. The solution to this is introduction of a new prefix, PF, which is unique for frozen section cases that can be assigned directly in the frozen section laboratory. This prefix was introduced 1 year prior to introduction of the new DPS, and this will also ensure the logistics, for example, the pre-printed labels are sorted out and the department is familiar with the concept and the naming convention. In addition, we need to create new procedures in the LIS to distinguish between the frozen section slide and the subsequent paraffin block slides. Because last time how we used to do it is that once there's no label, we know that it's a frozen section slide. But we cannot do that anymore. And we need to be able, since all the slides are labeled, we need to be able to distinguish them by the unique procedure. So for example, as you can see in the bottom, the labeled slide in the left, which is HEFS slide, is actually the frozen section slides. And the HEFS embed is the paraffin fixed block of the frozen section tissue. Furthermore, the high acuity nature of the frozen section laboratory demand quick LS accessioning and slide entry, and a quick method was introduced during the actual DPS expansion project. The other benefits of a unique PF prefix is that there's clear identification that this case is a frozen section case upfront when the pathologist receives the case. It's easy to track the workload of the frozen section because when the number ends in the year, that will be our workload. And it's also easy for us to retrieve the frozen section case for audit. And it allows us to readily transition to computerized physician order entry for the CPOE or CPOE workflow. And I must say that we are one of the few hospitals regionally, if not globally, to apply computerized physician order entry for our frozen section cases. So all our frozen section cases would have the digital order that is actually viewable in our LIS when we receive the frozen section case. We will now look at specimen or part accountability. We will illustrate this with an example of a specimen requiring immunofluorescence and electron microscopic examination, like renal or skin biopsies. Previously, when the immunofluorescence and the electron microscopy specimens were received, these were noted in the request forms and reports, but were all grouped under the specimen or part A in the LIS, with separate manual tracking by special laboratory teams being done. The single part approach was also in view of a single microscopic description generated against all the materials rather than separate parts. The issues with such an approach, if we scan or incorporate the whole slide image or other images from the IF and EN specimens, or should they be subsequently used as paraffin materials, the block and slides thus generated may not be reflective of their origin. So the solution is to assign the different parts to each specimen. This will allow downstream accountability of the blocks and slides with clear specimen parent, and future proofing of the solution even if the current solution addresses only routine surgical pathology. So for example, if we incorporate immunofluorescence image and electron microscopic image in the future, we will be able to actually reflect them clearly from different fragments of tissue. So if we assign them at different parts, the issue to address is to change the reporting practice to generate a single microscopic description incorporating the multiple parts. And the immunofluorescence and the electron microscopy teams needs to incorporate practice to update routinely in the laboratory information system, which they didn't use to do so. The other benefits of the separate part assignment is that there's ease of identifying the presence of the immunofluorescence and electron microscopic specimens directly from the laboratory information systems. And the potential of tracking the immunofluorescence and electron microscopic workload from the LIS exists with such an approach. We will now look at a potentially more complex problem, which is slide accountability. This is talking about uniquely tracking and identifying each and every slide being produced. Now, in the past, the focus of the LIS data entry was on blocks and specific procedures for generating slide labels. There was no slide identifier concept, as slides with the same procedures and from the same block used the same slide label printout, as you can see on the top left hand. And any unique slide or different levels is actually reflected manually in the pen mark. And immunohistochemistry procedures were documented in the laboratory information system, but they are now coded as specific procedures, as the slides generated directly from the automated stainers were submitted as is with the original auto-stainer labels that you can see in the bottom left. Hence, there's also no slide identifier concept for the immunohistochemistry slides in the LIS. And the case accession and block numbers were keyed in as text data in the automated stainers. And tracking of the stain orders were done manually and via the automated stainers. So how do we actually do this as we actually transition to introduce DPS? Now, the introduction of the whole slide imaging scanning, or the DPS, in the diagnostic workflow require comprehensive slide identifier concept, which means each and every slide must be accountable and uniquely identifiable. Now, this may seem simple, but actually require relatively broad consideration, and is one of the most major change for the laboratory, if not previously introduced. And within our LIS, we have to ensure all the stain procedures, including the immunohistochemistry stains, are uniquely set up within the LIS. Hence, extensive discussions took place to ensure various exceptions, although the exceptions are not altogether rare, like double color immunohistochemistry stains, 2 blocks in a single slide, and repeat stains are considered. The actual practice of slide identifier or slide identification requires the strict discipline within the laboratory, as there can only be one slide identifier for a single physical slide submitted. You cannot reprint the slide identifier for a different physical slide. And hence, this will require education and change management of the technical staff and the technologists. Other benefits of introducing the LIS slide management is that there's more accurate tracking of the workload by actual number of slides generated, and the potential to automate tracking of immunohistochemistry and other specific procedure orders can be done within the LIS. We had also further refined our stain setup to incorporate the most common double stains to be set up as fixed coded stain names, so as to avoid free text entry that we used to do, as seen on the top right. This will require additional effort and cannot be readily used for automation and analysis if we actually stick to the free text as qualifying text. So we eventually actually used the free text entry to analyze what are the most common double stain combinations and created unique procedures to it, just as we are doing it. For example, you can see here the CD3 and CD20. We have the corresponding procedures for a double stain of CD3 with CD2, for example. Although digitization of the glass slides into whole slide images certainly has its workflow advantages, what is more exciting is that it has created a new dimension to the practice of anatomical pathology, which is the use of computer vision and computational methods to study specimen images. We have seen this slide earlier as a reminder to how we may potentially use digitized whole slides of specimens. I will now share some of our own experience in the use of whole slide images with analytics and machine learning tools. One of our earliest experience in using computational technology on whole slide images is in biomarker analysis on immunohistochemically stained slides. ER, PR, and HER2 biomarker analysis in breast cancer is one of the earliest areas being studied and developed. And they are both CE, which is the European standard, and FDA, which is the US standard, approved computer-assisted solutions available. The picture above is taken from our own systems and a system which we have previously used. And here we can see that the system has been able to pick up stained nuclei and assign intensity scores based on the legend. Furthermore, the analytics tool can readily count the number of nuclei based on the intensity and compute parameters like H-score readily. We have also published our experience a few years ago using image analysis for Ki67 proliferation fraction to look at prognostication of breast cancer. In this case, the pathologist first trained the image analysis system to recognize tumor versus non-tumor like stroma. And we used tissue microarray of 440 cases with 3 cores for each case, in which we took the highest Ki67 score derived from the image analysis system among the 3 cores. Hence, it is the hotspot approach in counting Ki67. And we found that the Ki67 cutoff of 14% is shown to differentiate between cases with higher recurrence and lower overall survival on multivariate analysis. We have also published our experience a few years ago using image analysis for Most recently, we have studied the use of artificial intelligence on breast fibroepithelial lesions. The fibroepithelial lesions comprise fibroadenomas and phalloides tumor. And fibroadenomas and phalloides tumor have different clinical management, for which women with fibroadenomas are subjected to imaging surveillance or simple enucleation, while those with phalloides tumor require surgical removal with clear margins. However, diagnosing the fibroepithelial lesions can be challenging, as phalloides tumor mimic fibroadenomas radiologically, hence require histopathological evaluation to make the diagnostic separation. So for this AI project, we aim to develop a more objective and rapid detection tool which could assist pathologists in accurately diagnosing the lesion in core needle biopsies. We first used the AI algorithm to filter out white spaces and artifacts like folds and ink before generating the patches we see on the top right that will be analyzed using convolutional neural network. We then use the outputs of the convolutional neural network and put this through the recurrent neural network for slide level prediction. And we are able to achieve 95% accuracy in the prediction of phalloides tumor. So in conclusion, digital pathology represents a recent major advancement for anatomical pathology, allowing us to unleash huge potential of the tissue sections on glass slides with application of computational capabilities. Implementation of digital pathology is not simply plug and play of scanning device, but require proper integration with existing workflows and systems, and sample laboratory information system so as to associate the images with valuable clinical specimen data. We need to ensure comprehensive accountability of specimen assets as well as the derivatives. Otherwise, the slide scan may lack relevant metadata for the whole slide imaging to be meaningful. A good digital whole slide imaging foundation can allow us to look forward to embracing additional computational layers and capabilities, and investments and efforts in whole slide imaging put us in a good position to further investigate the use of artificial intelligence and imaging analytics in anatomical pathology. With this, I would like to thank the audience for the attention and the patience. And apologies for any glitches and mistakes that I've made in the meantime. Thanks.
Thank you for your amazing lecture. Dr. Cheng told us why we need digital pathology. Compared with glass slide, digital pathology has many advantages. It can be widely used in pathology teaching, scientific research, and clinical diagnosis. Dr. Cheng share his insights on how to integrate WSI process into the diagnostic workflow. He spent a lot of time and do great job. I'm so impressed of this part. Maybe many experience we can learn from. Finally, he gave some prospect of digital pathology. We know digital pathology is the basis of telepathology diagnosis, artificial intelligence assisted pathological diagnosis. He give us some examples about AI projects, including breast cancer and fibroepithelial breast lesion. Fantastic work. Thank you. Next is the discussion time. The online audience are welcome to ask questions in groups. We can collect questions and submit them to professors. Now let's invite Dr. Shi Ruoyu to give us comment or the discussion of some issues. Welcome.
Okay, thank you, Dr. Chen and Dr. Liang. I'll try to moderate this question and answer section. There's already several questions on the line, so probably I will share questions here. I will repeat the question in Chinese and translate into English. Okay, first of all, actually, it's my own question. And Dr. Chen, about the laboratory staffing to establish a digital pathology system in a department, how much manpower do we need, including administrative staff, technician, and pathologists? 这个问题就是想问 Dr. Chen，如果要建立一个数字化的病理的一个小组，在一个病理科室的话，它需要多少的行政人员，需要多少的实验室技术员和专职的病理医生去维护这个系统？谢谢。
Thanks. I think the core team, as I mentioned earlier, will need to consist of at least about 1 to 2 pathologists, and it will also need to consist of at least a senior laboratory manager that will help actually coordinate any the parts of the laboratory workflow that will depend on digital pathology. You also need 1 to 2 medical technologists or laboratory technologists that has experience with whole slide imaging and the laboratory information system to be able to manage the quality control of the slide scanned, as well as manage the scanning process. And you will also need at least a project manager to plan the project, to actually ensure that the project timeline is met, as well as manage the finances of the project. And you also need your information technology solution partners that will actually help to manage hardware, software, and, for example, cybersecurity aspects. So I think, but the involvement, the exact time of involvement actually varies between the different stages. So of course, the involvement will actually be more intensive when you are implementing, and probably less intensive when you are actually maintaining. But I think the people involved, we try to actually keep it as consistent as possible so that there's actually familiarity and there'll be no issue of knowledge transfer between implementation and maintenance. So 我就用中文来解释一下，我们的核心团队差不多有1到2位的病理科医生，至少有1位高级化验室的技术经理，还有1到2位对全视野数字切片与化验室信息系统熟悉和有经验的化验室技术人员，还有你要有至少1位专案经理来处理专案规划、流程与财政，还有几位资讯科技技术人员来处理硬件技术、资讯科技与网络安全等等。但是当你在刚开始来推出这个系统的时候，你的时间方面可能就会需要花多一点时间。当你在你的系统已经稳定了一段时间过后呢，可能你就不需要花每一位核心团队成员都不需要花太多的时间去维持这个系统。但是我们尽量让不要有太多的人员转换，这样子的话呢，我们就不会面对就是说没有办法让我们的技术能够传承下去的问题。还有一个就是化验室行政人员的参与也非常重要，因为他们是化验室信息系统的核心使用者。
好的，谢谢Dr. Chen。接下来我讲一下这个观众提出的一些问题。第一个问题是说，如果一个科室每天产生2000张病理切片、1000张 H&E、1000张免疫组化切片，采用扫描仪能否自动识别切片，包括二维码，并且自动的进行病例的分配，特别是按照各个系统进行自动分配。 就是说 if the pathology department generate 2,000 slides a day, 1,000 H&E slides and 1,000 immunohistochemistry slides, will digital pathology system be able to assign these cases, especially assign based on the organ systems?
Yes, potentially yes. It actually depends on what you how you actually assign your cases within your laboratory. So example, if your assignment is actually recognized upfront when you accession the case, and you know which pathologist this case will actually be assigned to, then since the information is already in the laboratory information system and will be transmitted into the digital pathology system, this will actually be automatically assigned to the pathologist, and the pathologist will actually see the case assigned to him in the work list in the digital pathology system. Now, if your metadata actually contains also the type of tissue or the organ system this specimen belongs to, and your laboratory actually assigns based on the organ system, or your pathologist is organized into teams based on the organ system and can pick up the cases automatically based on the organ system, then I think the digital pathology system will be able to actually potentially organize the various work lists if the information is actually in the metadata. For our laboratory, because the pathologist is actually already assigned upfront, there is actually no the pathologist work list would have actually reflected which cases is actually assigned to him. So it really depends on how your laboratory actually assigns the case, and to automate the process, you will need that information in the metadata. 所以我就简略的用中文来讲一下。所以你们其实要自动的分配的话呢，其实你的原数据或者说你的全市数据全市资料。就是你的那个全切片全数字切片的全市资料和原数据呢，需要有相关的信息。如果你在你在接收病例的时候，你已经知道是哪一个病理科医生需要去处理这个病例的时候呢，其实当你的这个病理科医生的资料已经在那个数字切片的全市资料或者原数据里面呢，其实它就能够自动的把这个全数字切片呢就是分配给那个医生看。如果你是需要用你的就是系统病变的方式的话呢，这样你的系统你的病例的系统或者生理系统需要在你的全市资料和原数据里面。Thanks。
好的，谢谢Dr. Cheng。像第二个问题是，每位医生第二天早上可能每天要看几百张各种不同的切片，那么一个科室或者医院系统能否做到自动分配吗？比如说每一个医生他早上来一来上班的时候，开始工作的时候，电脑系统会自动提示他一天有多少张片，比如说150张片子，而且已经自动分类。就说 Will the digital pathology system being able to notify the reporting pathologist in the morning of the day how many slides have been assigned to you today?
Yeah. So actually, it depends. You can do it either via laboratory information system or digital pathology. You don't have to always use digital pathology system for this respect. So in our laboratory information system is able to actually bring up the work list of the cases that has been assigned to you, including the active cases and the new cases. So we can track it via the laboratory information system. And we are actually also updating this work list to actually reflect which cases have digital slides associated with them. if you want to do it via the digital pathology system, I think that will need to be inherent in your digital pathology system to be able to do that. It really actually depends on the capability of the digital pathology system, but I think potentially that's possible. But for our laboratory, we do it via the laboratory information system. 我就简略的用中文讲一下。其实这个可以在就是你的LIS 或者是你的化验室的信息系统里，其实是可以去来显示说你今天还有过去有多少你还有多少病例是需要去处理的。其实这个我们是用我们的化验室的信息系统来就是通过我们化验室的信息系统就可以看得到了。不一定需要全数字切片系统去看。当然你的全数字切片系统如果有这样的功能的话当然是最好。但是我们在我们的医院里面我们是通过我们的化验室信息系统，因为我们的化验室信息系统就也是已经接收到说哪一个病例呢其实是有数字切片，哪一个病例是还没有数字切片的。Thanks。
好的，谢谢 Dr. Cheng。接下来2个问题有不少问题是有关于存储的我把它总结一下，然后变成2个问题。第一个问题是如果说一个病理科一年有100万张切片，如果都扫描成数字切片的话如何储存？就是 if a department has 1 million slides to do a whole slides imaging, how much is the storage and how to storage?
Okay, so storage is always a challenge, and I think this is one of the things that you do actually have to plan early. If you actually want to if you want to actually scan a substantial number of slides, if you're actually scanning, for example, in ad hoc or in very small volumes, it's probably pretty straightforward. You actually store everything in a hard disk. Usually for security, for facilitating the workflow, you will want to actually do it in an enterprise grade storage systems, but usually that will not be, if your storage is small, that will not be a big problem. If you're talking about 1 million slides, that can go up to, if each slide is actually about even 500 megabytes or 1 gigabytes, you can be talking about petabyte size storage. This type of storage you need to carefully manage. It is actually very difficult and very expensive to manage petabyte size everything online. So you either will need to actually think about storage that is actually more archival type of storage, a storage that may be slightly slower to retrieve, but will be cheaper. So for example, tape drives or tape libraries, or you might want to consider storing it on a cheaper storage on the cloud if that is something that you can do. There are archival type of storage that will allow you to, that will not allow you to read-write very often, but that will allow you to actually store the images more cheaply. It is actually unrealistic and very expensive to store everything online. So if you are scanning 1 million slides, my advice is to really speak to your IT consultant to come up with a storage strategy and include cheaper storage in the process. 所以我就简略的用中文来讲一下。如果你是扫描100万个切片都扫描成数字切片的话，其实你的储存就是用普通的电脑的储存的话呢，其实应该是不太实际的。就是用电脑的储存能够很快速的把你的数字切片来读取的话呢，其实是不现实的。所以你要看一下有没有办法用处理，就是以比较 节省的方法呢，来处理比较旧的数字切片，他们可能需要一点点花多一点点时间，像半个小时这样来读取，就是刚开始来读取的时候呢，可能需要半个小时，但是过后你读取了，当你已经把这个在比较我们说 archival storage 就是比较省钱的，或者是比较省事的那个储存的地方呢，读取之后呢，你之后的读取应该是会比较快速的，但是你需要去斟酌一下你的那个储存信息的方法你可能没有办法把所有的东西呢都储存在好像普通的电脑的储存 hard disk 的储存里面这个可能是不太实际的。谢谢 ，Thanks。
好的，谢谢 Dr. Cheng。其实后面还有一个问题，就是紧跟着这个比较类似的这样一个问题，就是说数字切片是永久储存的吗？就是热储存还是冷储存这个成本是如何的？就是我觉得热储存还是冷储存，可能就是 Dr. Cheng 讲的是 archive 还是这种 live storage， 其实差不多吧。就 so has the are the digitalized slides storage are permanent or temporary? Are they archive or non-archive? How to afford the cost?
Yeah. So right now we try as hard as possible not to delete cases. We have not yet actually deleted the slides as up to now, the ones we actually scanning. I think it's a matter of putting the older scanned slides into the archival. And the more recently scanned slides into the active storage. 所以我用中文来简略的讲一下，就是我们热储存和冷储存都有用到，比较最近扫描的全数字切片就是在热储存里，比较旧的数字切片呢就是在冷储存里，我们都有用到。我们到目前为止还没有删除我们扫描的数字切片。Thanks.
OK， 接下来有一个问题是关于软件应用的。所以就说它是用英文问的 so any quantitative histopathology software application cases share the difference between machine learning and AI。 我想就是说他可能是要问有没有已经我们正在使用的这个AI 相关的一些或者是用AI 辅助的这种应用在我们日常的工作当中的软件，就是这些软件有没有应用的。
Right now we are actually still investigating the actual use of the software. We have actually, as mentioned, we have tried the quantitative biomarker analysis. I think what we want to really do and felt would be more useful is to do it at scale. Automatically recognize tumor versus non-tumor throughout the entire whole slide image and quantifying the biomarker analysis. Right now, a lot of the commercially available solutions are still requiring you to actually mark out the various areas before they can actually do the quantitation. So we are actually in the process of actually looking for something that would be more convenient, because actually there are many solutions that's quite capable of already doing biomarker analysis. We don't find it realistic for us to develop our own, but I think it's trying to actually combine solutions that recognize tumor versus non-tumor together with the biomarker analysis that we are actually trying to look for and hopefully to be able to implement, because I think we have a real need to make sure that to objectively also do a second level quality check about the scoring, especially when the scoring actually affects prognosis and treatment. about the difference between machine learning and AI, actually, they are kind of slightly different, but they are actually overlapping. Many people actually refer to AI with deep learning, equate AI with deep learning. So the technology behind a lot of the artificial intelligence related solutions is actually deep learning. So for example, convolutional neural networks or recurrent neural networks. That means the neural network related technologies. There are, for machine learning, I think if you want to look at it more broadly, I think the deep learning strategies could also be considered machine learning. But there are other more traditional machine learning methods that machine learning as a term would actually be referring to. So we usually do not, when we talk about machine learning and AI, there is sort of some implicit difference, but they are actually overlapping concepts. Yeah. 这一方面我就我翻译方面可能我会比较有挑战性啊，不知道梁教授或者是石博士有什么其他的见解？
I also have a question for Dr. Cheng. To fully digitalize the diagnostic work in your pathology, I want to know the investment about money and equipment. Does the hospital support the plan?
Okay, so all the funding actually comes from the hospital. We were quite fortunate we initially have some ministry funding for the pilot project, but subsequently when we expand, etc., it's mostly hospital technology refresh, etc. is actually hospital supported. I think the investment actually is substantial. And I think you do have to actually make a business case out of it. It's a bit sensitive to actually say how much, but I think it's also quite difficult to actually talk about an equivalent when I think the cost and manpower, etc., is actually different. It was substantial for us because our manpower cost is also a bit high in terms of implementation. What is more important, I think, in looking at this experience is to make sure that you have actually encompassed everything within your costing, and make sure that you have your investment and business case actually incorporating everything that you need to cost for. So the things you need to cost for will actually include the server to actually support the digital pathology software, as well as your storage. Storage actually cost is very substantial, and you need to really actually plan for it. So you need to actually plan how much you need to scan, and at least the advice is to plan at least for 5 years to ensure that you don't run into storage issues. 5 years is also logical because many of the technology refresh occurs at around 5 years. You need to consider also the scanner cost and any licensing cost associated with connecting the scanners to the servers, because this will also depend very much on the vendor that you're actually dealing with. Okay, so it's not just the scanner cost, but it's also the server cost and the software cost and the hardware cost. Now, you also will need to actually cost for network, PowerPoints, etc. All these you will actually need to ensure that you have the sufficient connectivity, because actually once you have network latency or you have a bad network, I think the system cannot work. So you need to actually, for us, we ensure that you need to at least have 1 gigabit connectivity. The more the merrier. You just do not want latency to occur when you actually access your system. And then, of course, the other peripherals like PowerPoint, you need to ensure that you have sufficient space. And the most important thing is actually, another critical thing is manpower. A lot of the manpower it's not only manpower incurred by the vendor, which they would actually code as part and parcel of the service that they will provide, usually installation of the software, but also any internal information technology costs that your hospital will have to bear. You also have to consider, because that is actually also part and parcel of the cost. And any of your internal laboratory staff costs that will need to be incurred as part and parcel of the implementation project. So I think all in all, you need to make sure that it's actually comprehensive. Of course, I think in China, as well as in other countries, they may be able to actually find more solutions which is actually more economically viable, and that will may be associated with a lower cost. For us, we are more dependent. A lot of our solutions actually need to be from the international market, and that may actually incur a higher cost from our side. Thanks.
Okay, thank you. We have talked about many questions. Because of time limitation, we have to end the part of our discussion. Finally, I would like to thank for Professor Cheng and Professor Shi for your wonderful talk. And thank for our online audience for their listening and good questions. Thank for Dakewe Academy for their support. Okay, thank you. Let's invite Lei to give a summary of this meeting. Okay.
Hi, Dr. Liang. Thank you so much. Also, we will really appreciate that Dr. Cheng to bring us the wonderful lecture today and the sharing in detail the experience of the SGH hospital in the clinical application of digital pathology. And because I was a histotech working in the hospital, so the contents related to this system connect to the DPS, and also include the IHC. So those processes very impressive to me. And thank you, Dr. Cheng, also bring us the recent advance in diagnostics when using the digital pathologist AI function. So during our discussion sections, the professors exchanged their experience in digital pathology. And also tonight, our audiences are from different countries around the world. I got some data like in Chinese, we got like 92%, and Indonesia, we have 3%, Singapore have 2%, also from the America and Philippines, Turkey, Brazil, and Japan. So, we have a lot of audience tonight, actually. And we also really appreciate Dr. Shi for translating the audience's question for us. Thank you so much. I think because of the pandemic, so we have to have our lecture online. But I think after a couple of months, hopefully after a couple of months, we may meet on site and we can continue to communicate with each other. So yeah. Thank you so much. Well, actually, we have some more questions, but I think because of the time limit, we may not be able to answer all the questions during our webinar. So I think after that, maybe Dr. Cheng or Dr. Shi or Dr. Liang may share their contact information. If our audiences have more questions, we also can communicate with each other offline. So yeah, I think tonight's webinar is really successful. So really appreciate three professors spending the time with us tonight. So thank you.